You're listening to the Future Tech Health Podcast with Richard Jacobs. Until I reached age 40, I never realized the obvious, that we all have medical issues, or we at least have a family member or close relation that had, has, or will have them in the future. Medicine and biological systems are the final frontier. Until we've conquered death, figured out how life began, cured cancer, and understood our purpose in the universe, there's a heck of a lot to talk about when it comes to our health. Future Tech Health means I'll be covering futuristic topics that are actually already in clinical trials, or even starting to appear on shelves or by prescription, or available for your own use. We dive deep into stem cells, CRISPR-Cas9, the science of sleep, epigenetics, medical testing, cancer, ketogenic diets, stem cells, aging, regenerative medicine, and more. My goal for you, the listener, is to learn from these podcasts. You may very well learn something that may change the course of your life for the better, steer you towards a new career, or give you insight into addressing a serious medical problem. Remember, however, this podcast and its content is informational in nature only. No medical, tax, legal, financial, or psychological advice is being given. If you enjoy the podcast, please listen, subscribe, like, and share it with friends. Thank you. Hello, this is Richard Jacobs with the Future Tech and Future Tech Health podcast. I have Chuck Meakin. He's a doctor and now medical director of the Care Oncology Clinic in the USA. And there's, I believe, a sister clinic over in the UK. He joined this June after 30 years of radiation oncology in his previous life. So we're going to be talking about, I don't want to talk about the old stuff. I'd rather talk about the new stuff because I've heard good things about the Care Oncology Clinic. So I hope you're okay with that, Chuck, and welcome.
Yes, Richard, that sounds wonderful. So I'm excited to dive right in and spread the word about a project I really believe in and have dedicated the second part of my career to.
Yeah, that's the first question there is why, after so long doing one thing, have you moved over to this clinic? What prompted you?
So there was a few nudges along the way, and it's been teasing at me for years. Back to grade school, high school, I was always interested in sort of Eastern thoughts on and what influences outcome with people, what their mindset was, what their diet was, what their lifestyle habits were, and was a student of martial arts, yoga, was a vegetarian for a while, well before people of my age genre thought about that kind of stuff. And so as a busy 12-hour-a-day oncologist in a wonderful hospital outside of Charlotte with a lovely, large group of oncologists, I was always a little bit on the outside, looking at alternatives to standard of care that would, favorably impact without side effects the outcome. I pursued, further study in nutrition. I pursued further study in complementary therapies. I became a bulletproof coach in 2016. I was tuned into the whole metabolic theory of disease maybe 15 years ago, and now it's just starting to get some traction in the United States. So I also I'm in a family of people that have a disease course or a minor problem called retinitis pigmentosa, which is a slow decay of your peripheral vision. And although my family's been blessed and we've had a longer course than most, in December of 2018, I went up for my every 2-year check-in at Massachusetts Eye and Ear, which in a few years ago had some studies in it, and that's what was attracted to me to it. And they said, gee, you've decayed a little bit. You're still an outlier. Most people have trouble in their 30s and 40s and 50s, but you now are below the 20-degree peripheral vision for a certain test intensity, and that makes you legally blind. So after asking them to repeat that, I said, oh my goodness, this changes everything. You cannot be a legally blind director of a cancer center in sort of a visual-based field. We looked at MRIs and CT scans and PET scans all day long. I also did prostate implants and a lot of visual work. And so I powwowed with my team and my wife and family, and I asked permission to finish out the month because I had some important things I felt like I had committed to, people who came to me from a distance for prostate implants. And so the end of December,
Okay.
told my lovely cancer team, when I leave today, I'm gonna ring the bell because it's my last day. And that worked out okay. I immediately heard about this entrepreneurial program at Notre Dame where I did my undergrad, and thought about that. And then I ran into the team from Care Oncology. I had been introduced before, and I tried to get their protocol out of a hospital unsuccessfully, but I ran into them again, and it was perfect alignment at this point. I knew I wanted to continue to work in oncology to bring, metabolic and alternative strategies to the mainstream, and this was my easy ticket to do it. Sorry for the long answer.
Yeah. No, it's fine. Well, you mentioned it very briefly just now, so that the Care Oncology Clinic, instead of the normal triad of just radiation, surgery, and chemotherapy, they do things differently. So can you talk about how and why and what they do differently?
All great things start with a story, usually a story of love and pain. And that's how people get out of themselves and break barriers. And this has that same element. Robin Bannister, one of our beloved co-founders, was helping manage his wife. He's a PhD pharmacist, but his wife was already a few cycles or a few rounds of chemotherapy into things with stage 4 breast cancer back in 2008 and 2009. And what I had heard is at that point, there wasn't many options left. As a creative pharmacist who'd already assembled some drugs in a creative way, he knew about repurposing of drugs, namely that most drugs have 4 to 6 molecular pathways of activity, yet they only get designed and sort of labeled for one use. And we all know what these are. Minoxidil was found to grow hair on the head, although originally designed for high blood pressure. Viagra was originally designed for pulmonary hypertension and was found to be helpful for erectile dysfunction. So there's actually a basket of these wonderful drugs that have secondary effects against cancer. And it's listed on what's called the redoproject.com. And at the time, that wasn't available, but Robin looked through the world's literature, found 100 drugs that had activity, found by accident against cancer, but designed for something else, weaned it down to 10. Nobody can take 10 extra medicines. He weaned it down to 4, and then suggested that they take 3 medicines, 2 all the time, and then 2 in alternation. And these were the medicines that had different activities against cancer, different pathways, were real well vetted for safety, were also generic at the time, so they're inexpensive and easily available. And he put his wife on these, and she stabilized for a few years and ultimately did pass from her breast cancer. But he felt this was too good an idea to let go to rest. And he worked together with Gregory Staloff. And together they formed Care Oncology in 2013. I heard about it through a lecture I went to and said, boy, this is brilliant. I've heard about repurposing of drugs. This will help lower costs. We know about these side effects because of years of monitoring, and they work differently than the cytotoxic, kill cells. And there's a lot of collateral damage as well with chemotherapy. The more regional treatment with radiation, which some cells are more vulnerable than others, but in general, there's long-term damages. And then thirdly, now with biologic therapies, some of those are targeted, but usually just to one metabolic flaw in the cellular growth pattern, and generally don't work upstream in the full messaging of metabolic proliferation. Our metabolic protocol works very upstream in that it blocks metabolically signals for proliferation. And in doing that, it greatly down regulates proliferation messaging to cancer cells and works in all the ways we've heard of it. It increases cell kill when chemotherapy is used or radiation. It also blocks new blood vessel formation. It disrupts membranes. It upregulates a pathway to improve suppression of cancer cell proliferation. And additionally, it works against all the other things we're at risk for to get in trouble in life, like cerebral vascular disease, cardiovascular disease, neurologic problems.
I have a quick question here. This is a difficult one, but why do you think that drugs have 5 or 6 different pathways instead of just the intended pathway in the body?
It's
probably
just
unanswerable by you, but what's your speculation?
My hypothesis is that you can't impact one thing without impacting a few different cascades. And there's probably more than 4 to 6. There's probably 4 to 6 main ones, and then there's secondary and tertiary ones. But the 4 to 6 main ones are the ones that are known about. And for instance, these 4 drugs, if you go to clinicaltrials.com, which is the U.S. government list of human trials, there's currently over 90 trials currently with our main drug, metformin. There's over 30 with statins, our second drug. There's over 13 with the antibiotic doxycycline, our fourth drug, and over 3 with mebendazole, our fourth drug. So there's a lot of interest in these. We're the only ones that use all 4 together and have a vetted trial that showed efficacy against a very, very difficult to treat tumor.
Which cancers do you work with in using this 4-drug mix?
So when they started the company, Richard, they knew they had to get traction. So Gregory and Robin worked hard to get some access to putting a trial together. They didn't have the billions of dollars to do a randomized trial. So they did a patient-matched control where in England, everybody got the standard of care with brain tumors, glioblastoma, the one that just caused the death of lovely John McCain. And he lived about a year and probably had the best of possible care available to him. So 95 patients were treated with surgery, generally radiation and a mild chemotherapy, and then some got further chemotherapy, and some got a electromagnetic treatment called Optune. And 95 were given this 4-drug cocktail along with it. And most didn't even start it until 6 to 7 months into it. And instead of having virtually the best outcome, which we see in any of the literature between the US, UK, and Europe, which is about 2 in 10 live to 10 years. Live to 2 years. Nobody lives to 10 years, but 2 in 10 live to 2 years. And in the care oncology subset, the 95 patients, 58% lived to 2 years. And many of those patients didn't really start the drugs until pretty late in the actual treatment. And only about 1 in 10 had to stop any one of the medicines for any side effects. So we since have treated another 185 patients, and that first group of 95 was published in June of this year in the peer-reviewed journal Frontiers of Pharmacology. And the second cohort is going to be further analyzed and ultimately published. But now, in addition to brain tumors, after that proof of efficacy, and that tumor hasn't changed the outcome. For the 30 years I've been treating cancer patients, we treated a lot of people with glioblastoma. Now we're treating all types of high-risk cancer, like mainly colorectal cancer, breast cancer, some sarcomas, ovarian cancers, and GYN cancers, lung cancers, and prostate cancers. Firstly, it works against any type of cancer because all cancers have similar sort of metabolic flaws.
So what are the functions of these 4 drugs as you understand them? Like what's metformin's role? What's doxycycline's role? Can you step through them generally, or is that not your area?
Well, I'm a clinician, but having now worked with care oncology and sort of put together a technical review, I'm familiar with how they work. Metformin was it's originally from the lilac plant. It's been around for 30 to 40 years. It's used to make your body more sensitive to insulin. So you tend to have lower blood sugars and therefore lower insulin levels, and that's important for long-term health of type 2 diabetes and a lot of other inflammatory diseases. But it's also very important for cancer. And it's believed that cancer cells are primarily dependent on the use of sugars or gluconeogenesis for the production of their ATP, their energy production. And if you pinch that off or you reduce that, they become less likely to grow and more at risk to damage by chemo and radiation. And that's why fasting works, and that's why getting a ketogenic diet works, and that's why pharmacologic management, like with metformin and atorvastatin, work, because they create almost like a pharmacologic fasting state. Now, it's not just the effect on the blood sugar results in the impact. It also works down a lot of metabolic pathways that are more scientific in their name, like mTOR, which it downregulates. That's our body's propensity to make new cells. It slows that proliferation. It upregulates a surveillance pathway called AMP kinase, and then it works selectively against the tumor potential to make new blood vessels, which is how tumors spread. So it works richly and works synergistically with the statins. And then the other two drugs, doxycycline and mebendazole, worked in knocking out any closet infections that could be present. Doxycycline is like the all-purpose antibiotic. It has effects against malaria, Lyme's disease, atypical infections, Rocky Mountain spotted fever, and then standard infections, bacterial infections. But it also has anti-proliferation effects. And they both have been shown in laboratory models to kill cancer stem cells, which are sometimes the inert cells that tend to not be knocked out by the other modes of treatment because they don't divide all the time, which, the other pathways of treatment work on dividing cells. So the four together have a synergy, and Care Oncology through Robin Bannister saw that and put them together, and they're really well tolerated. So patients find us through the internet. They get a virtual telemedicine consult, so they don't have to leave their home. And just like we're doing, you can link in other family members through the Zoom consult. And we now cover all of the U.S., and we cover part of Canada. And we have an all-oncology panel. So everybody will see an oncologist, and all our nurses are oncology trained and oncology certified. So we've kind of switched greatly since I got involved in May, and we now see people. Brain tumors are probably only 10 to 20% of the common cancers we see.
So this includes diet suggestions, or do you require that people have go on a ketogenic diet in addition to the drug taking, or is it just the drugs?
Richard, that's a great question. We know that the ketogenic diet is very important in our brain tumor population, and because of that, on our panel we have consults with Miriam Kalimian, who wrote the main book on ketogenic diet for cancer. So consults or sort of work with her is available through our website for those patients who want them. We think that's real important with our brain tumor patients. It's probably less critical with the other, prostate, colon, breast, lung, and whatnot. So we offer it, but we definitely encourage it with the brain tumor patients. And most people are really, that whole, you can sort of basket case all the different diets into sort of a grouping of either wide non-eating window or low carbohydrate or ketogenic, but mainly the thing they have in common is low carbohydrates with a period of some non-eating through the day, which further increases your insulin sensitivity and lowers your blood sugars. And once again,
so you mean like intermittent fasting or time restricted feeding?
Yes, exactly, Richard. And so I don't get too technical on which one of those is right. I just say some version that works for your lifestyle. And once again, I discuss everything in an 80-20 format. Well, if you do it 80% of the time, you're probably going to get most of the results without getting too, nervous and anal about it.
Yeah, no, that makes sense. Okay. So a bit of intermittent fasting, the protocol varies, and then this cocktail of these four drugs. And how long is the protocol, and what do you observe happens to people during the initial parts of it and then through the time period? I don't know if it's 8 weeks or a year or how long it is.
So the way it works, Richard, ideally, perfect case scenario, we're starting to see this in a few cases. We'd like to start right after diagnosis of a high-risk cancer. And I define a high-risk cancer as someone who has less than a 50% 5-year survival. To me, a coin flip's not a good bet to be around in 5 years. So if you can use this along with standard of care, and we have white papers meaning a scientific-based paper on the utility of this in virtually all the cancers, prostate, lung, breast, sarcoma, you name it, gliomas. And so we try to start it as early as possible. And then the patient would get their standard of care, which could be, surgery, radiation, chemo, or just chemo, or say some lymphomas. And then we try to use this for at least 2 years to continue to downregulate it. And after 2 years, and then we can only write a prescription for 3 months. So the patients see us, get a 3-month, we have nursing follow-up in the middle of that. We have a helpline. And then 3 months later, we then do another follow-up and initiate another 3 months of and we sometimes modify the medications. And we'd like to go 2 years. And then we are currently about to release what we're going to call a remission protocol, and ultimately a prevention protocol. But the remission protocol is a derivation of these 4 drugs, but at a lower dose and at less frequency. So we like to use it for 2 years to really drive the proliferation into the dirt. And of course, normal follow-up staging and tumor markers are done during that time by the standard of care physicians.
So do you see people mostly with metastatic cancer, or do they just have a primary tumor? And if so, what do you see in those 2 cohorts, after a year or 2 year of treatment?
Good question. What we see a lot of is people that have, gone down the standard of care route and had progression on chemotherapy. Maybe it's their second-line chemotherapy. Now it may be chemotherapy with some of the new targeted treatments, from precision medicine. And they realize that, the hope that they're going to get this fixed with the path they're on is unlikely. And we see them jump in with us, and, they might even be seeing their tumor markers fail or their imaging start to show fail. And once they get metabolic blockade on it, which is sort of the final blockade of the moat of cancer cell proliferation, maybe the chemotherapy was only working partially, or the hormonal therapy or immune therapy. And what we usually see is then the tumor markers start to go down and their progression diminish. And so we see that a lot in those people that join us as they fail. What we see from people who join us before they fail, or as they start their adjuvant chemotherapy or initial chemotherapy, is we see a much higher rate of response. And this doesn't add too much side effect burden to their pathway. I mean, there's a little bit of diarrhea with one of the medicines, about 5 to 10%. There's a slight chance of raising your liver function with the statin, and we monitor for that. And then there's a little bit of possibility of upper GI irritation with the doxycycline. And we that's why we have a physician monitor this. We've had 6 years of expertise in monitoring through our teammates in England and Center of Excellence. And so there's a fair amount of tricks for this. Like the brain tumor protocol is different than the non-brain tumor protocol. And we try to get to a stable dose, and we can go up if we need to. So yes, it's different depending on what stage we see people. Ideally, we'd like to see people as early as possible.
Well, that leads to a big question. Do people have to go through a certain percentage of the standard of care to be allowed to go see you? Or can they, as soon as they find out they have cancer, go see you first?
So we've had both. We've had is a organization that supports doing the standard of care to the degree one can. We always encourage people to do that. In fact, I just saw a breast cancer patient who really was a good candidate to get simple hormonal blockade for her metastatic breast cancer. And I was the one that got her back to a new oncologist in North Carolina to get that started with our metabolic blockade. But Richard, some people have already burned all their bridges with the second line, third line chemotherapy, and they really just do care oncology alone, possibly with some diet interventions. Others, I've had a patient from Southern California who, with his eyes and his wife's support fully open, has a HPV positive base of tongue tumor. He said, I know I can do standard of care at some point. I'd like to. He did some expensive alternative care in Mexico. Then he found care oncology. Our program is kind of a bargain. In general, it costs about $2,000, a little over $2,000 a year for medication and doctor oversight. Although there's a patent on the 4 drugs, we ask our partnership pharmacy to charge the lowest amount they can to get all 4 drugs to people for a 3-month interval. This man from Southern California ended up using just our products, and he monitors the lymph nodes in his neck along with diet. And he's gone into it with his eyes open, and I've encouraged him to stay close to his ENT surgeon with follow-up exams and imaging. But he has just said, I think he coaches his kids. He does. He's in his late 40s. He just knows that he would like to hold off on the side effects of standard of care therapy as long as possible. We don't recommend that, but there's examples of that.
And then do people actually go into remission through your protocol, or is it more that, they'll have metastatic disease and the metastatic disease just doesn't progress anymore? Or do you have stories where the metastatic tumors will actually go away and leaving them maybe with a primary only, or all the tumors go away? Like, what are the range of outcomes you've seen?
We've had the whole range, and in general, it works better with there's some standard of care on board, but we've had people stabilize on COC alone. We've had people regress on COC alone. And of course, we know, and I hear people saying this, there is the placebo effect. And if something works, I'll take the placebo effect any day of the week. I do know we offer people a supportive environment to consider, these are all drugs that, ironically, Richard, if we could wiggle our nose and get rid of all cancer in the United States, it would only increase the average lifespan by 2.5 years, because the things that cause cancer also, group together and cause cardiovascular disease, neurovascular disease, neurodegenerative disease, and metabolic disease like, diabetes and such. So these 4 medicines have some impact on all those. So it's, in my mind, if you have a high-risk situation, it's an easy yes to consider something that would impact the cancer, but also the other things in life. I personally use some of these medicines for longevity and prevention purposes, and believe in this metabolic theory.
So the all 4 of the drugs are off patent and generics are used for all 4 of them, or is there any name brand left that manufactures these?
No, they're all off patent and been generic for a while. There is one little hiccup there, and this is not uncommon in the U.S. pharmacology pharmaceutical market. One of the drugs was so cheap, it was actually bought up by another company. It used to be like 30 cents a pill, and they immediately made it's mebendazole. They immediately made it like $400 to $500 a pill, which most people only use a pill or two for the worm. So the indication. So it's one of those. It's like the EpiPen. And so what we have done is, and then there's a veterinary version of it, which has a different activity and hasn't been tested like ours in humans. And so what we did was, our partnership pharmacy is the biggest compounding pharmacy in the United States. They cover all the states, and they have been able to reformulate it in a way to recreate the original ingredients. And we sell it as cheap as we can along with the other drugs. But truth be told, probably 75% of the monthly cost, which is $60, 70-80% of it is related to mebendazole. The other ones are pretty simple and less expensive. Now, Oncology was able to get
a question. What's a quick question before that? What's the largest compounding pharmacy in the U.S.? What's the name?
It's called MedQuest.
MedQuest. Okay, I'm just curious. So, are you saying Oncology? Go ahead.
Yeah. So, Oncology, after they showed efficacy in this, they got a use patent on the 4 drugs, so that they put a lot of time, since 2013, a lot of work into proving its anti-cancer benefit. So they have a intellectual protection there on the way these are used for anti-cancer strategies, and that covers U.S. and this covers North and South America, and then there's patent for Europe and the rest of the world as well. But at this point, we're trying to get the word out and trying to make metabolic oncology sort of the 4th or 5th wheel of oncology care. And this really aligns with me. For years, I was challenged to understand why the NCI dedicated cancer centers in the United States had no consistent policy on nutrition. And it was usually just say, eat anything, just make sure you don't lose weight. And we know that for the rest of us without cancer, you can have, 2,000 calories from, some fast food place every day, or you can have 2,000 calories from, the best holistic food place, and you're going to get a different outcome. I think that also applies to cancer patients as well. So I think we're learning more, and I believe that there is going to be slow movement. One of the things that we're noticing is that for the first time, one of the PARP inhibitors came out and said, this new, and of course these are all $20,000 a month drugs, which is sort of a real challenge, in our system. But it said to use this effectively, you need to be on a low carbohydrate diet. And then we saw a paper that showed that for those people that were doing a low carbohydrate diet, and I believe this was with a TKI, the outcome, it was for lung cancer, the outcome was like a 30-month median survival versus a 4-month if one was not. So we're starting to see some separation where outcomes are different based on what kind of lifestyle someone has and kind of nutritional strategies they subscribe to. I know in my life, I go to school with 55 robust 20-year-olds, so I have to be on my game. I'm in the Notre Dame entrepreneurial program, which is all STEM background to people who are trying to bring new companies to market or scale up new companies. So it's an incredibly rich environment for learning and working hard, and also fixing things that matter. That's sort of the tagline. And I know that my diet and exercise habits keep me up with those 20-year-olds, and it's made it doable for a 60-year-old. So yeah, I'm glad to see that some of the standard of care, guidelines are starting to reflect that.
Well, that's great. So what's the expansion plan for Care Oncology, or how's it going to ramp?
So as I mentioned at the beginning of this, we are just now raising some. We are profitable in the United States from the start. We are moving along, and we're constantly getting busier. New things that are on the horizon for us. We are about to initiate an 800 number so people can call in. People now can schedule themselves and upload their labs and imaging without going through one of our intake managers. Once again, we have an all-oncology nursing and doctor staff. We hope to get full coverage of Canada. One of our physicians is licensed in 3 provinces, and he's working on the others. And we hope to bring out our Remission Protocol and then ultimately our Prevention Protocol, in the next 6 to 12 months. And the Prevention Protocol is going to be very exciting. It will be a derivation of our drugs with some mapping to supplements that have similar effects. We'll also partner with a exciting new company that has proprietary strategies to use blood tests to find markers for the prediction of cancer, and possibly additionally partner with some new imaging modalities to do safe, non-X-ray inducing imaging to find cancers earlier. So it's going to be a layered thing where you can just do the protocol for prevention. And crazy to say, Richard, 1 in 2 men, 1 in 3 women get cancer in their lifetime. And of those people over 50, if you match out the 20% have HPV, a bunch have genetic risk, BRCA1, BRCA2, Lynch syndrome, those kind of things, and then add on to that, family history or sort of work exposure like pilots or firemen, I can name many. It ends up being about 70 to 75% of the people, over the age of 50 have some risk of cancer. So we think that's an area where we can partner with insurance companies and use the insurance companies to help us provide this and show them how they can help their members avoid cancer and probably other medical problems, and help the insurance companies spend a lot less money. Because we know every diagnosis is going to lead to about $100,000 to $200,000 of cost, depending on the specific diagnosis, and that we know that the diagnosis of cancer is the leading cause of medical bankruptcy. So, and those that get bankrupt, the risk of death goes up threefold. So we hope to bend that curve of incidence and then lower the cost. And that's why I got into it, because, as a Stanford trained oncologist, I knew that, the developments in care were exciting, but we were missing some stuff that everybody could access. In addition, as an econ major at Notre Dame, I knew that we had an unsustainable model currently, and this uses repurposed generic drugs that are safe and work against multiple things, and they can be delivered from a home environment and work by basically starving cancer.
Well, very good. Yeah, I didn't realize the numbers were so dire. I mean, that's completely unsustainable for the average person to have to spend $100,000-$200,000, and it to be, if you combine men and women, 40% of the population. It just can't be.
Yeah. So we're raising some money so we can grow faster. Some of our goals are to, we got some traction in the brain tumor population. People are finding us on the internet through our new study that was published, and our website is careoncology.com, where you can access all our white papers and the publication and a lot of patient testimonials and whatnot. Actually, The Economist, the magazine, without any prompting from us, did a expose on the beauty of the whole concept of repurposing drugs, and made a video of one of our patients and how it, she was failing with breast cancer, and how it, changed her outcome, and how this is a true opportunity to use some old technology to lower costs and help people with the care of their cancer. So we hope to raise some money and then grow this and get more into the standard of care so people know about it. And, physicians who are doing their best at big institutions, but also know they're under sort of a big brother eye to always advocate the NCCN guidelines or the standard of care, they have plenty of data to support a care oncology protocol, and we're the ones that will provide it. We'll take the headache, off them, and they don't have to write the scripts and follow the liver function test. They can just, bring it up with their patients, especially the patients with really high risk diagnoses where the outcome is the standard of care is, dire, is unfavorable.
Well, very good. Well, Chuck, thank you for coming. The work you guys are doing is super important. And what's the website, or how can they get in touch with the clinic for people listening?
Yes, it's easy to use. It's careoncology.com. Careoncology.com. It's a little confusing. It's called Care Oncology Clinic in the UK, and sometimes people find it's like, oh my goodness, I don't find the US clinic, but it's Care Oncology US. And it, if you call over there, call the 800 number, they'll direct you here. And we got a wonderful team. Our team, we have monthly brain trust to kind of update ourselves on the new findings. We have 6 years of expertise from our UK partners, and many of the people who work with us are, if they're not a caregiver in oncology, they're a survivor. So these are heartfelt people that want to make a difference. And we got a growing list of wonderful stories of, I do these Zoom meetings with young people who happen to get a brain tumor early, and they haven't had a recurrence in maybe a year or two. They started with us early, and with a glioblastoma, that's really unusual. And their doctors who are sort of watching them with the standard of care are starting to say, yeah, you're different than most of the people I see. What are you doing? They're doing the Care Oncology Protocol, and they're maybe doing the Ketogenic Diet with us. Got a lovely teacher I was talking to who has a following of his whole school out in California. I was speaking to a lovely pilot recently who had to give up his pilot's career, but is so far totally stable on the protocol. We have a young woman out in South Dakota who's like over 2 years, never having a recurrence. And of course, in England, where they've been doing this for 6 years, they have even longer stories that are real exciting to see, especially in the tumor glioblastoma, where we don't usually see standard of care doesn't usually see as many good results.
Well, very good. Well, Chuck, thank you for coming on the call. I appreciate it.
You bet, Richard. Keep up the good work, and appreciate being here today. Thank you.
You're listening to the Future Tech Health Podcast with Richard Jacobs. Until I reached age 40, I never realized the obvious, that we all have medical issues, or we at least have a family member or close relation that has, or will have them in the future. Medicine and biological systems are the final frontier. Until we've conquered death, figured out how life began, cured cancer, and understood our purpose in the universe, there's a heck of a lot to talk about when it comes to our health. Future Tech Health means I'll be covering futuristic topics that are actually already in clinical trials, or even starting to appear on shelves or by prescription, or available for your own use. We dive deep into stem cells, CRISPR-Cas9, the science of sleep, epigenetics, medical testing, cancer, ketogenic diets, stem cells, aging, regenerative medicine, and more. My goal for you, the listener, is to learn from these podcasts. You may very well learn something that may change the course of your life for the better, steer you towards a new career, or give you insight into addressing a serious medical problem. Remember, however, this podcast and its content is informational in nature only. No medical, tax, legal, financial, or psychological advice is being given. If you enjoy the podcast, please listen, subscribe, like, and share it with friends. Thank you.